outcome trials, and I'll be ending my talk with some clinical info. So how does this molecule, this SGLT2 inhibitor, decreases the HbA1c? It does it by induction of glucosuria. So what happens in the proximal tubules is there are two transporters, SGLT1 and SGLT2, and 90% of glucose gets reabsorbed via SGLT2, and 10% gets reabsorbed by SGLT1. So the net effect being a minimal or a zero glucose excretion. So once you give SGLT2 inhibitor, there is around 70 to 80 grams of glucose excreted per day, which amounts to around 280 to 320 kilocalories loss per day, and this results in around 3 to 4 kg weight loss in most of the individuals. So in normal individuals, the renal threshold for glucose excretion is around 180 mg per deciliter. And what happens in type 2 diabetes individuals, as the plasma glucose level increases, so what we think is, normally it should have happened is, the kidney should be excreting more amount of glucose in the urine, but that doesn't happen. So what happens is, and there is a paradoxical signal. As the plasma glucose level increases, there is a paradoxical signal telling the kidney that as the glucose level increases, you hang upon to the glucose. So thereby the renal threshold also starts to increase. So when the HbA1c is 6.5, the renal threshold will be around 200, and when it goes to 9, the renal threshold level becomes 240 to 250 mg per deciliter. So when you give SGLT2 inhibitors, so on starting it, so what happens is the renal threshold, the threshold gets reduced to way below the fasting glucose levels, that is between 40 to 70 mg per deciliter. Once you start giving this drug, for example, if the fasting glucose level is 180 or 200 mg per deciliter in a diabetic patient, you start giving this SGLT2 inhibitor, the patient will start to pour more excess amount of glucose in the urine because the renal threshold is way below, like it's around 50 or 60 mg per deciliter. And this happens irrespective of the diabetes status. If you give to diabetic or non-diabetic individual, the same thing happens. So now you might be thinking like, okay, if such is the scenario, then now it should be more prone for hypoglycemia. No, that doesn't happen actually. So why it doesn't happen is because of two mechanisms, two hypotheses have been explored. So one is a signal, as the patient excretes more amount of glucose in the urine, a signal goes to the liver, which leads to increase in glucose production, which more or less equates the amount of glucose which was lost in the urine. And if the patient is reaching the hypoglycemia level, and the SGLT1 gets activated more, and it leads to thereby preventing the hypoglycemia. So before I move on to the trials, so this is how the risk-benefit ratio, this is how the risk-benefit ratio should be calculated before we prescribe SGLT2 inhibitors. The benefits being insulin-independent decrease in HbA1c, irrespective of the disease duration, and A1c reduction of 0.6 to 0.8%. There are low hypoglycemia rates, and a modest decrease in weight, and a modest decrease in blood pressure, and decrease in albuminuria, and modest decrease in triglyceride, and increase in HDL level. The risk being increase in urinary frequency, genital yeast infections, UTIs, risk of dehydration, and reversible small decrease in GFR, and increased fracture risk. This was observed only in the CANVAS trial, but in subsequent meta-analysis, this was not proven. The same applies with for amputation. And euglycemic decay. This happens mostly in type 1 diabetes, where when it's being given as an off-label indication now. So moving on to cardiovascular benefits. So this was the first trial with the SGLT2 inhibitor, which showed a significant improvement in cardiovascular outcome. This is the EMPARAG outcome trial, which was published in 2015. And the three 3-point MACE was the primary outcome for our MPARAG trial, and the 3 points being cardiovascular death, non-fatal MI, non-fatal stroke. So overall, 14% relative risk reduction was observed in this trial. You might wonder, this was just 14%, this is a robust decrease. So what is the significance? Here we should consider 1 point from the MACE, which is the cardiovascular death. See this graph. This is the Kaplan-Meier graph. So in this graph, you might be noticing the graph starts to separate way early in the trial period itself. This has never occurred previously with respect to all the major hypertensive statin trials. So this was a major achievement, and it showed around 38% reduction, relative risk reduction in cardiovascular death. So these are 5 major outcome trials: MPARAG outcome, Canvas, Declare, TIMI, Credence, and Vertis CV trial. And the time to first for the time to first MACE from the pooled meta-analysis, there was around 10% risk reduction. And for time to CV death, around 15% relative risk reduction was observed for CV death. And for hospitalization for heart failure, around 32% risk reduction. Remember this, in these 5 trials, this is hospitalization for heart failure was a secondary outcome only. No one was expecting such thing. So then because of these things only, proper heart failure trials were later done. And irrespective of whether the patient had baseline heart failure or no heart failure in the trial study, in the study groups, so those who didn't have any heart failure, they also, there was a significant delay in development of heart failure in such patients during the entire trial period. So these were the major heart failure trials, which included both the heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and they included both diabetic as well as non-diabetic individuals. And from the pooled meta-analysis, there was around 23% risk reduction for heart failure hospitalization or cardiovascular death in heart failure trials. So moving on to kidney benefits. So this MPARAG outcome, which showed around 39% relative risk reduction in worsening of nephropathy. And so during the initial period, which was seen in most of the SGLT2 inhibitor trials, there will be a dip in EGFR. But as days progress, it plateaus out, and clearly you can see around a 3-year period of time, this thing, in the placebo group, there was a significant dip in EGFR, whereas in the SGLT2 inhibitor group, the EGFR plateaus out. And time to first renal composite outcome, there was a relative risk reduction of around 38% in all the major outcome trials. And these are proper CKD trials. So the Credence, DAPA CKD, and EMPA kidney. In Credence, they included the type 2 diabetic patients, whereas in DAPA CKD and EMPA kidney trial, both the type 2 diabetes and non-diabetic individuals were included. And from the meta-analysis, it has been shown that there is around 37% relative risk reduction in all these from these trials. So moving on to guidelines, ADA update. So if there is ASCVD or high-risk cardiovascular risk factors, straight away you have to start the patient on SGLT2 or GLP-1 receptor agonist. If the patient is having heart failure, SGLT2 inhibitor. If the patient is having CKD, either SGLT2 inhibitor or GLP-1 receptor agonist should be started. And if your goal is about achieving and maintaining weight and glycemic goals, then for weight, yes, apart from GLP-1 receptor agonist, SGLT2 inhibitor also do play a role. And for maintenance of glycemic goal also, SGLT2 inhibitor. And there is some off-label indication for MASH, mast cell or NASH also. So how to prescribe this? This slide is mainly for glycemic control. If you are planning to start the patient on SGLT2 inhibitor, first thing what you should check is EGFR. You can start the patient on dapagliflozin if the EGFR is more than the 15. For canagliflozin, you can start if the EGFR is more than 45, and for EMPA, you can start if EGFR is more than 60, but it can be continued if the EGFR is till 45, and better to stop. This is primarily for glycemic control. With respect to CKD progression, you can start anything like if it is the EGFR is more than 20, you can start the patient on SGLT2 inhibitors, but you won't be getting any glycemic benefit, but the CKD progression benefit will be there. This EGFR more than 20 is based on the EMPA kidney trial. So pearls and pitfalls: hypoglycemia only if the patient is also on insulin or sulfonylureas. When you are starting SGLT2 inhibitor, better to reduce the insulin dose by 20% of what already the patient is on, and then initiate it. Volume depletion and acute kidney injury is a transient thing. If it is if the creatinine rise is more than 30%, then you have to evaluate for other causes. Genitourinary infections. So this from I'll be having a mixed opinion on this. This is from the 2024 review article. So from all the data, what they are seeing is the SGLT2 inhibitor is not associated with an increased risk of UTI, but there is 3 times higher risk of genital mycotic infection with SGLT2 inhibitors. Females are more affected than the males, and Fournier's gangrene is also very rare and is not associated with increased risk of UTI. So what they are saying is, with regards to new SGLT2 initiation, it is not contraindication, not contraindicated if the patient is having asymptomatic bacteriuria. If the puzzle is 10 and the patient is asymptomatic, you can generally start. And for recurrent genitourinary infections, should be evaluated for other underlying causes. And the SGLT2 inhibitor can be safely initiated if an underlying cause is resolved. So they cleverly haven't mentioned when to restart, as they have mentioned it can be safely initiated if the underlying cause is resolved. And if the patient develops genitourinary infections while taking a SGLT2 inhibitor, and the routine discontinuation is not recommended. You can continue in mild to moderate cases and clinically stable severe genitourinary infections. And SGLT2 discontinuation might be warranted in the setting of life-threatening infections, and risk significantly outweigh the benefit. So when to restart after genitourinary infections? Restart as soon as possible. If the infection is effectively treated, no other contraindication, you can restart. And you have to monitor it. They are saying that the recurrence again is highest within the first 2 weeks of SGLT2 initiation. So repeat the urine routine after 2 weeks. This is from the 2024 article. And we have one consensus for Asia Pacific countries. So here what they have mentioned is those who are having recurrent UTI, we should evaluate for underlying risk factors. And if they are UTI free for more than 1 year, then you can start the patient again on SGLT2 inhibitor. This sounds more or less valid. And if you are practicing, you can try that 1 year free interval. So next is euglycemic DKA. So euglycemic DKA, this is a very rare entity, but it can happen during the perioperative period, or if someone prescribes SGLT2 inhibitor in lean diabetes individuals or type 1 diabetic patients, this can happen. So it is how to treat it. It's more or less the only thing is in the ABG there will be high anion gap metabolic acidosis, but there won't be any hyperglycemia. It won't be more than 200. So you just treat it like DKA, treat with IV fluids and insulin therapy. So when to use SGLT2 inhibitor diabetes, the type 2 diabetes with heart failure, with CKD, with cardiovascular disease, and with obesity. For if the patient is having, the one thing about all these trials is they didn't show any benefit in stroke. So if the patient is having stroke, it's better to start on a GLP-1 receptor agonist when compared to SGLT2 inhibitors. When to avoid recurrent genitourinary infections, type 2 diabetes, LADA, and type 1 diabetes, that is the lean people. If the patient is having orthostatic hypotension, frail elderly group, advanced peripheral arterial disease with amputations, and history of Cori, these are all corifornius gangrene. It's plus or minus kind of, we have no direct evidence to say, yeah, this is going to lead to fornius gangrene. So the major question is like, what is the patient is in ICU, whether everyone will be having a question, whether this thing SGLT2 will lead to euglycemic whether it will happen to every patient. So this was answered by the Defender trial, which was published in the first week of July. So here around 507 ICU patients were included, and DAPA was administered. And here you can see that there was no ketoacidosis, and the 2 cases of mild hypoglycemia was alone observed. And there was no increased risk of AKI, and there was no mortality benefit also. So it just, it's basically a negative trial. It just answers that whether everyone will lead, the drug will lead to euglycemic decay in all the patients. So maybe in critically ill patients, you can consider stopping SGLT2 if the patient is in shock, metabolic acidosis, or severe UTA, and whom to consider continuing SGLT2 if the patient is in heart failure. So this is the approach to starting SGLT2 inhibitor therapy. If the EGFR is more than 20, definitely yes, no. If the EGFR is less than 20, do not start SGLT2 inhibitor. This 20 is basically for CKD progression delay, that's all. If if you want glycemic benefits, you have to follow the previous slide which I had mentioned earlier. So if there is a history of UTI, genital infections, high-risk population, you counsel them on a proper genital urine hygiene, and then start on SGLT inhibitors. Avoid excessive alcohol consumption and ketogenic diet and adequate fluid intake. And once you have started SGLT2 inhibitors, monitor kidney function after 2 to 4 weeks in high-risk groups, particularly more than 55 or 60 years. And if the baseline creatinine rises less than 30%, fair enough, you continue SGLT2 inhibitor. If it is more than 30%, you exclude other causes of AKI. Better to involve nephro also. And if the monitor and if the patient develops genital mycotic infection, you treat and continue SGLT2 inhibitor. During periods of acute illness or infection or surgery, you can temporarily discontinue SGLT2 inhibitors and reintroduce after once the patient starts taking orally. So summarizing, SGLT2 inhibitors are relatively recently introduced drugs for type 2 diabetes exerting their A1C lowering effect through glucosuria. They are associated with modest reductions in BP and weight and do not lead to hypoglycemia. The side effects being polyuria, possible dehydration, genital yeast infections, and possible euglycemic decay. And they have shown to reduce MACE, cardiovascular death, or heart failure hospitalization, mainly in patients with type 2 diabetes and overt cardiovascular disease. They also reduce the progression of kidney disease in type 2 diabetic patients and high risk or renal risk. And more recently, large-scale outcome trials have shown that these diabetes drugs also improve heart failure outcomes in heart failure, irrespective of the diabetic status, and reduce CKD progression, irrespective of type 2 diabetes. And type 2 diabetes treatment guidelines now encourage early use of these agents in those with cardiovascular disease, heart failure, and CKD. Careful patient selection is important, avoiding them in those at the greatest risk of adverse events and complications. Thank you.